All right, welcome back, everybody, to another deep dive into the world of 340B.
Yes, welcome.
Now, things never seem to slow down, do they? There's always something happening with 340B.
That's for sure. It's a dynamic program.
So today, we're really zeroing in on, I think, what a lot of people in the 340B world are thinking about. It's all those state-level legislative moves, especially when it comes to contract pharmacy access.
Right, exactly.
And we also want to kind of shift gears a bit and see how some of your peers out there are taking those 340B savings and really turning them into better patient care.
Yeah, I think that's going to be very insightful.
So we've got a lot to cover, a bunch of recent news articles and also a great conversation with a leader from a major health system. And I think it's going to be a really informative session.
Sounds good.
So to kick things off, let's just jump right into this whole legislative scene at the state level.
Okay.
Things have been so busy.
They have.
There are a lot of states tackling this whole issue of 340B contract pharmacy access.
A lot of activity.
Yeah, like Nebraska, for example. Their bill, LB 168, the one trying to stop drug manufacturers from putting limits on 340B contract pharmacies, well, it's already passed 2 votes in the chamber, and it's moving towards a final decision. And the Nebraska Hospital Association, they see this as a really big win for healthcare in the state.
That's a significant development. And, what's interesting about the Nebraska case is there was some pretty strong pushback.
Oh, yeah?
Yeah, there's this group, Building America's Future, and they ran some pretty intense ads against the bill. And according to Senator Hardin, the bill's sponsor, they were a little misleading,
Oh, wow.
So, I mean, it just shows you how much is at stake for these drug manufacturers.
It does.
And the lengths that they'll go to.
Yeah.
At the state level even, which is interesting.
Makes you wonder, where they're putting their resources these days, right?
Yeah, for sure.
Now, Senator Hardin didn't hold back either.
No, he did not.
His response was pretty strong.
It was a heated debate.
It was. Shows just how controversial these issues can be.
Absolutely.
So let's shift gears a little bit. Head down south to New Mexico. A Senate committee there moved HB 78 forward. This bill's all about protecting federally qualified health centers, those FQHCs, and the ones that are like them.
Right.
Those are those community health providers that get federal funding to serve those who might not have the easiest access to health care.
Right.
And it's trying to protect them from drug manufacturers trying to mess with contract pharmacies. But here's the thing, the protection, it's only for these FQHCs, not every covered entity in New Mexico.
Interesting.
Yeah, so with New Mexico, we see the Pharmaceutical Research and Manufacturers of America, PRMA, making an appearance.
Yes.
They're saying that states like New Mexico, they're overstepping their bounds, trying to set requirements that aren't specifically laid out in the federal 340B law.
Right.
But we've seen court cases, like the one in Arkansas, where that argument didn't really hold water.
Yeah, that's a good point.
But it's interesting, right?
Yeah.
Because PHRMA, they actually worked with the National Association of Community Health Centers, or NACHC, on the federal 340B stuff.
Yeah.
So why the different approach now at the state level?
It's curious, isn't it? Why the change in strategy?
Yeah. All right, let's hop over to Kansas now. Over there, the Senate Committee on Financial Institutions and Insurance, they gave the green light to SB 284. This bill is aiming to, beef up their existing contract pharmacy access law. The thing is, the Attorney General pointed out a while back that the current law, it just doesn't have any teeth, No real way to make people follow it.
Oh, I see.
So SB 284 comes in and says, hey, let's hit violators with some civil fines. And get this, that money from the fines, it's going straight into a Defense of Drug Delivery Fund.
Wow, that's a pretty direct approach.
It is.
Interesting.
But of course, PHRMA and BioKansas, they're not thrilled. They're saying 340B hasn't really done much for patients.
Right. That's the argument we hear a lot, isn't it?
Yeah, a common refrain. But, covered entities, they would definitely disagree. I mean, 340B is a lifeline for so many of them, helping them provide care for those who need it most.
Absolutely. It's crucial for their operations.
Okay, let's move east now. Over to Connecticut. They've got this big drug pricing bill, SB 11, making its way through it. It's got some 340B contract pharmacy protections tucked in there, but it's specific. It covers FQHCs, family planning clinics, Ryan White clinics, and the University of Connecticut Health Center.
Okay.
But not all covered entities.
So it's a bit more targeted in its approach.
Yeah, and get this, 2 Connecticut health systems actually spoke up, saying they wanted broader protections.
Interesting. So even within the state, there are different perspectives on how far these protections should go.
Absolutely. And of course, PHRMA chimed in.
Of course.
They're saying 340B is just ripe for abuse, and they're calling it a hidden tax.
It seems like those are their go-to arguments against the program.
Right, you hear those a lot. All right, now let's swing over to Colorado. They've got Senate Bill 71, which has passed a committee. Now, this bill's a bit of a heavyweight. It wants to block any drug manufacturer from messing with 340B contract pharmacy access for every covered entity in the state.
Wow, so it's a much broader approach compared to Connecticut.
Yeah, much more sweeping. And on top of that, they're saying hospitals got to report their total 340B savings and show how they're using the money.
Okay,
And this actually lines up with what the American Hospital Association is pushing for.
makes sense.
But it's interesting because, the people supporting this bill, they're adamant that it's not about expanding 340B.
Mm-hmm.
It's about making sure it works the way Congress intended it to.
Right, upholding the original intent.
Yeah. And then you have Senator Rich talking about how a lot of Colorado hospitals, they're barely breaking even, some even in the red. It really hits home how important those 340B savings are for them to, keep providing care in their communities.
Absolutely. For many of those hospitals, it's the difference between keeping their doors open and having to cut back on essential services.
Exactly. Now, Colorado also had this other bill, SB 124, that wanted to set very specific rules on how certain hospitals should use and report their 340B savings. But that one is on hold right now. They need to make some changes. And honestly, a lot of hospital advocates weren't too happy about it. They felt like it was too restrictive and could actually hurt the program and the good it does for communities.
It's an interesting dynamic, right? On the one hand, there's this push for more accountability and transparency in how 340B savings are used, which is understandable. But on the other hand, hospitals need a certain level of flexibility to address the unique needs of their communities, and overly prescriptive rules could potentially undermine that. It's about finding the right balance.
It is. We've got a couple more quick updates from Kentucky and South Dakota. So Kentucky had this contract pharmacy access bill, SB 14, that actually sailed through the Senate. But get this, in the House, they threw in a bunch of extra reporting requirements for providers, and it basically killed the bill. The sponsor was not happy.
Oh, wow, that's unfortunate. Sometimes those legislative processes can take some unexpected turns.
They really can. But on a more positive note, South Dakota just became the first state in 2025 to actually pass a contract pharmacy access law. They're joining 8 other states that already had something similar in place.
That's great news for covered entities in South Dakota. It's encouraging to see more states taking steps to protect access to the program.
It is, and actually over 25 states have introduced bills like this just this year. Clearly, this whole contract pharmacy access thing is a hot topic.
It's definitely top of mind for a lot of stakeholders right now, and it really underscores the ongoing efforts to ensure that covered entities can continue to leverage the benefits of the 340B program.
And that despite the pushback they're getting from drug manufacturers.
Exactly. I think this all really sets the stage for our next topic, which looks at how those hard-earned savings are being put into action.
Yeah, exactly. So we got to hear from Mark Riggle, who's the Assistant Chief Pharmacy Officer at UC Davis Health.
Oh, nice.
This is at the 340B Coalition Winter Conference. And we talked about how UC Davis Health, it's this big academic medical center, right?
Okay.
And they cover a huge chunk of Northern California, including a lot of rural areas where it's harder for folks to get good health care.
Right.
And their 340B savings,
Yeah.
super important for things like cancer care and helping patients pay for their meds.
Wow, so they're really using those savings to support some critical services?
Absolutely. What I found really interesting was how they're using their 340B savings to do more with clinical pharmacy services.
Oh, that's smart.
Yeah, Mark really emphasized that pharmacists, they are the medication experts. They can educate patients, help manage side effects, and be a huge help to doctors who are dealing with complicated cases. He even called them physician extenders.
Physician extenders. That's a powerful term.
It is. So they've got these clinical pharmacy services in a couple of key areas. First is direct patient care. That's where pharmacists actually work one-on-one with patients, often because a doctor referred them. They help folks manage chronic conditions like diabetes, high blood pressure, even weight loss.
Okay.
And the big focus is on making sure people are taking their meds the right way and that they really understand what can sometimes be some pretty complicated treatment plans.
That's so important.
Right. And the results, they're pretty amazing. Like their primary care patients with diabetes, they saw a real improvement in their A1C levels.
Oh, wow.
And they had a big jump in the number of people hitting their blood pressure targets.
That's fantastic. It sounds like they're making a real difference in their patients' lives.
They are. And then there's all the behind-the-scenes work they do to help the doctors and other providers,
Okay.
like managing refill requests. With some special agreements in place, the pharmacists can actually approve refills themselves, which take a load off the doctors.
Yeah, that's super helpful.
Right. And they're proactive. They reach out to patients who might be at risk of not sticking to their medication schedule.
That's great.
And they handle all that prior authorization stuff, which can be a real pain.
Oh, tell me about it.
They've got an 80% approval rate. And they've gotten the turnaround time down from like 2 weeks to just 3 to 5 days.
That's a huge improvement. I bet the doctors are thrilled.
Oh, yeah, they love it.
I bet it frees up so much of their time and energy.
Right. And then Mark talked about how using their own in-house pharmacies has really helped them capture more prescriptions.
Okay.
So not only does that boost their 340B savings, but it also leads to better patient care. They can track medications better, the pharmacists and doctors can talk to each other directly, and they can solve any medication problems much faster.
It's a much more integrated system.
It is. Now, financial assistance, that was another big thing that Mark highlighted.
Makes sense.
They've got these whole teams of technicians and pharmacists who are dedicated to finding patients who are struggling financially and connecting them with resources like copay cards, free drug programs, even their own UC Davis Health Waiver program.
That's incredible.
They really get how important affordability is, not just for accessing treatment, but for getting better overall.
Absolutely. It's a crucial piece of the puzzle. I mean, what good is a medication if the patient can't afford to take it?
Exactly. So for any hospitals or health systems out there thinking about doing something similar with clinical pharmacy, Mark had some great advice. He said, don't just focus on the money you might make directly. Think bigger. Think about the quality of care, those patient outcomes, how happy the doctors are.
Right. It's about the value it brings to the entire system.
Yeah. And get this, their goal was to give every single ambulatory care patient access to a clinical pharmacist. And they did it.
That's amazing. That's a testament to their commitment to this model of care.
It is. So when you look at all this together, the battles at the state level and how health systems like UC Davis Health are using their 340B savings, it just shows you, how important and how complex this whole 340B world is.
Absolutely. It's constantly evolving, and it requires a lot of attention and strategic thinking to navigate effectively.
So for all of you out there working with 340B, you really got to stay on top of these things. The legislative landscape, it can change overnight, and it can have a huge impact on what you can and can't do. And then there's the question of, how can I use my 340B savings to really make a difference for my patients?
Right, exactly.
Are you keeping an eye on what's happening with laws in your state?
Yeah, that's crucial.
Are you thinking about ways to do more with clinical pharmacy services, like what UC Davis Health is doing?
It's definitely worth considering.
These are the questions you need to be asking.
I think so too.
Well, that wraps up another deep dive into 340B. I hope this has given you some food for thought. And a big thanks to Aventi Health, an innovative 340B third-party administrator.
Yes, thank you to Aventi Health.
They really put their customers first, and their support helps make these deep dives possible.
Absolutely.
We'll be back next week to tackle more of the latest developments in the 340B world.
See you then.
But in the meantime, think about this.
Okay.
UC Davis Health, they've shown what's possible. So how can you take those same principles, making sure vulnerable populations have access to affordable megs, and apply them to the challenges your community is facing? It's a question worth pondering.
It is. It's about thinking creatively and strategically to maximize the impact of the program.
Absolutely. All right, until next time, stay informed, stay engaged, and keep up the great work you're doing with 340B.
We'll see you next week.